So most common cause of the PID is chlamydia trachomatis, and gold standard diagnosis is laparoscopy. After that, gold standard prognosis is bore Mosel, HSG never in acute PID or genital TB PID, worst fertility outcome hydrosalpinx plus IVF, salpingectomy, most sensitive sign cervical motion tenderness, most common long term complication infertility. Now we will go with question. Most common cause of the PID, it is chlamydotrachomatis. Most common cause of silent chlamydia, virgin female genital TB that does not spread sexually, genital TB, which is uh, common cause of chronic PID, chlamydia trachomatis. Organism associated with PID in IUD user, actinomyces israe. Most common cause of tubal infertility due to PID, it is the again chlamydia. Prognostic evaluation system is Bohr Mosel. System describes stages is Ganswelle classification. Stages of PID with tubo-ovarian abscess stage 3, ruptured stage 4, worst fertility stage 4. Most sensitive sign cervical motion tenderness. Most common symptoms is lower abdominal pain. Gold standard investigation is laparoscopy done routinely. No HSG is contraindicated in acute PID. HSG finding suggestive of tubercular salpingitis is beaded या pipe stem tube. Note a feature of tubercular salpingitis on HSG, wedge shaped defect at uterine isthmus. Investigation of choice for genital tuberculosis, endometrial biopsy. Best time to be taken endometrial biopsy in TB 1 to 2 days before menstruation. Long-standing pelvic inflammation may lead to pyometra. Most common long-term complication is infertility. Most common cause of ectopic pregnancy PID. Ultrasound feature in the PID thickened tube with free fluid. Imaging finding of tubo-ovarian abscess, complex adrenexal mass. CDC minimum criteria for PID include cervical motion tenderness. Antibiotic duration is 14 days. PID in pregnancy management, hospitalization plus IV antibiotic. Hydrosalpinx reduce IVF success because toxic tubal fluid. Best management of hydrosalpinx before IVF, salpingectomy. Most common site of tubal damage in PID, it is fimbriae and PID with normal ESR. Can PID be ruled out? No. Most common cause of PID worldwide, chlamydia trachomatis. In India, tuberculosis. Recurrence risk of PID described by Westrom. Hydrosalpinx is seen in chronic PID. Difference between hydrosalpinx and salpinx, clear fluid versus pus. PID without vaginal discharge suggests chlamydia. PID, can PID occur without STI? Yes. Next, granulomosa inguinal, donovenosis, causating agent Calamobacterium granulomatosis, now called as Klebsiella granulomatosis. Transmission, sexual or non-sexual contact. Incubation 1 to 12 week. Painless beefy red ulcer, multiple ulcer that causes no induration minimum or absent lymphadenopathy. Vulva destroy. Diagnosis, smear या biopsy show Donovan body, intracellular gram negative bacilli. Bipolar safety pin appearance. Treatment, azithromycin weekly or daily for greater than 3 weeks. Continue till lesion heal completely. Pap smear procedure is lithotomy position, per scapular examination, scraping with iris spatula. Per vaginal examination is not done before pap smear. Why PV is avoided? Because it remove exfoliated cervical cell, lubricate interfaces, bleed, obscure cervix, false negative result. Identify the squamocolumnar junction, endocervix scraped with cytobrus, fixed immediately with 95% ethanol. Screening with cervical, screening for cervical neoplasia. Normal physiological vaginal discharge is white discharge, no itching, normal smell, normal lactobacilli, acidic pH increase. Normal vaginal discharge physiological seen during ovulation, luteal phase, pregnancy and sexual arousal. Bacterial vaginosis, causative organism is Gardnerella vaginosis. It is thin grey white discharge, fishy odor adherent to vaginal wall, no itching, often asymptomatic. Clue cells are present on microscopy with reduced lactobacilli, no abundance of polymorphism, non-inflammatory. Nuisance criteria, gram staining, abscess, lactobacilli, Gardnerella, bacteroid or mobile incus. Mycoplasma is not included. Score 0 to 3 normal, 4 to 6 intermediate, 7 to 10 bacterial vaginosis. Diagnosis, M cell criteria 3 out of 4. Treatment is metronidazole or oral 500 mg for 7 days or clindamycin. Same treatment in pregnancy. False is that vaginal itching is present. In bacterial vaginosis, itching is absent. In the other hand, candidiasis, it is present. Discharge thin grey fishy greater than 4.5 clue cell. Metronidazole for bacterial vaginosis. Candidiasis, itching present, thick curdy discharge, no odor with normal pH, pseudo hypian. Treatment is azoles. Hysterosalpingogram is finding is bilateral hydrosalpinx. HSG feature dilated balloon pupil, contrast center but does not spill. Distal tubal obstruction causes chronic PID. Endometriosis. Importance is hydrosalpinx fluid is toxic. Reduce implantation management. Salpingectomy before IVF. अगर हिस्ट्रोसाल्पिंगोग्राफ में बायलेटरल हाइड्रोसाल्पिंग्स देख रखा है और एचएसजी में फीचर आ रखा है क्या, डायलेटेड बैलून ट्यूब है, कॉन्ट्रास्ट सेंटर बट डज नॉट स्पिल, मतलब वो है हाइड्रोसाल्पिंग्स के फीचर है. डिस्टल ट्यूबल ऑब्स्ट्रक्शन है. कॉजेज क्या होता है, क्रॉनिक पीआईडी एंडोमेट्रियोसिस के कारण होता है. तो इंपॉर्टेंस क्या है, हाइड्रोसाल्पिंग्स फ्लूइड टॉक्सिक होते हैं तो पहले साल्पिंजेक्टोमी करो. बीफी रेड पेनलेस अल्सर, ग्रैनुलोमासा इंग्वाइनल, बाइपोलर सेफ्टी पिन बेसिलाई, Donovan body pap smear order lithotomy, speculum iris spatula, PVA exam before pap smear is never. Fishy order no itching bacterial. Nugent exudates are mycoplasma, HSG, balloon tube, hydrosalpinx IVF, salpingectomy. Physiological leukorrhea, copious vaginal discharge, no itching, no odor occur 13 to 14 days after last menstrual period. Physiological leukorrhea is when normal vaginal discharge increase physiologically. Puberty, ovulation, pregnancy, premenstrual phases, occasionally white, clear, no pruritus, no foul smell, normal acidic pH, copious non-pruritic, mid-cyclic. Physiological. After that, physiological is no itching, mid-cycle, candidiasis, severe itching, curdy discharge, bacterial, fishy order, no itching, trichomonas, frothy discharge, itching and strawberry cervix. Bacterial vaginosis, altered vaginal flora, decreased lactobacilli, increased Gardnerella vaginalis, anaerobe symptom, thin grey whitish discharge, fishy odor, no itching, often asymptomatic. Diagnosis, EMSL criteria, homogeneous discharge, vaginal pH greater than 4.5, positive if test, clue cell greater than 20%. Nugent criteria, gram stain, lactobacilli, Gardnerella, bacteroid, mobilincus but not mycoplasma. False statement is bacterial vaginosis. Treatment is metronidazole. After that, Bartholin gland or cystia abscess. Painful unilateral swelling at the posterior introitus arise from obstruction of Bartholin duct, may form abscess if infected, and asymptomatic cyst observes abscess, incision, drainage and marsupialization. Pregnant women at term with active genital herpes infection, preferred mode of delivery is elective LS because it prevents vertical transmission, high risk during labor. Both primary and recurrent active lesion LSCS, no lesion, vaginal delivery. Drugs used acyclovir, valcyclovir, IV for severe disease. VBAC and induction is not allowed when active lesion are present. Mid-cycle, copious discharge plus no itching. Physiological, fishy order, no itching, bacterial vaginosis. Diagnosis is EMSL. Nugent criteria, Nugent exclude mycoplasma. Drug of choice metronidazole. Active genital herpes at term, elective LSCS. After that, painful unilateral vulval swelling is Bartholin abscess. Most common cause of PID, chlamydia, PID virgin genital, gold standard laparoscopy. PID spread via ascending infection with the sperm. Long standing pyometra. Chronic PID lead to frozen pelvis due to dense adhesion. Stages of PID described by Ganswelle. Prognostic is by Bohr-Meisel. Bohr-Meisel include prognosis, pregnancy outcome after PID. Now after that, investigation of choice for genital TB is endometrial biopsy 1 to 2 days before the menstruation. Balloon dilated tube filled with contrast on HSG. Hydrosalpinx is caused by distal tubal obstruction. HSG show dye enter but does not exit tube. Hydrosalpinx, most common associated hydrosalpinx is PID. Causative organism of granulomasa inguinal, Campylobacterium, Calimobacterium, granulomatosis. Dono and body are seen in granuloma inguinal, painless beefy red ulcer, granuloma inguinal. Correct order of pap smear stab है ना. Lithotomy, speculum iris spatula, pervaginal excision should be done after pap smear. Pap smear is used to screen cervical neoplasm. Copious discharge, no itching, mid cycle. Physiological, most likely cause of fishy is Gardnerella vaginalis, adherent to mucosa plus fishy bacterial vaginosis, curdy white discharge with intense itching, candidiasis, frothy greenish discharge, trichomonas. False statement about bacterial vaginosis that it is vaginal itching is present. Diagnosis EMSL criteria. Microscopic feature not seen is abundance of polymorph organism not included in Nugent score is mycoplasma. Vaginal pH is greater than 4.5. Clue cell bacterial vaginosis. Bacterial vaginosis is an inflammatory condition. False. Drug of choice in pregnancy metronidazole. Same in pregnancy. Preferred mode of delivery with active infection elective LSCS. Risk of vertical transmission is highest during labor. Drug used for genital herpes acyclovir. VBAC allowed. No painful unilateral swelling at posterior introitus. Bartholin abscess cause is obstruction of Bartholin duct. HSG showing bilateral club tube, bilateral hydrosalpinx, beefy red ulcer, bleeding on touch, granuloma inguinal, gram stain epithelial cell with fuzzy border, clue cells. After that, amenorrhea primary no menses for 15 years with secondary sexual character or 13 years without secondary sexual character. Kallmann syndrome, primary amenorrhea, hypergonadotropic hypogonadism, decreased GnRH, anosmia. Turner syndrome, primary amenorrhea. Secondary amenorrhea is absence of menses greater than 3 months in previously menstruating women. Sehan syndrome, postpartum pituitary necrosis. Asherman syndrome, Turner mosaic can cause secondary amenorrhea. Not a cause of secondary amenorrhea is Kallmann syndrome. Disorder of sex development, Swyer syndrome, 46XY, pure gonadal dysgenesis, primary amenorrhea, poorly developed breast, female external genital vagina present, uterus present, gonads absent, karyotype 46XY. Diagnosis is Swyer syndrome, differential are androgen insensitive syndrome, no uterus, good breast development, Turner 45XY and short stature. After that, effective surgery for those journal stress urinary incontinence is Cali repair, Passe repair, TVT, TOT, sling, Birch Culpo suspension, Pereira operation, laparoscopic bladder neck suspension, periurethral collagen insection. Not useful for journal stress urinary incontinence is Let's Go repair. Let's Go is used for the vesicovaginal fistula. So yeah, after that, menorrhagia is 80 ml blood loss or greater than 8-day bleeding with regular cycle. Stepwise management, first is NSAID and tranexamic acid. If non-hormonal fail, then hormonal therapy, OCP, progestin, LNG, IUS, GnRH agonist. If medical failed, endometrial ablation, uterine artery embolization, and last resort is hysterectomy. Next step after non-hormonal failure is hormonal therapy. Most important support of pelvic viscera is levator ani muscle, which include pubococcygeus, puborectalis, and iliococcygeus ligament, cardinal or uterosacral ligament. Secondary support, broad ligament, no support. Most likely procedure causing scar endometriosis is hysterotomy, classical LSCS, myomectomy, ventrofixation, episiotomy, but least like is hysterectomy. After that, female sterilization common method are Pomeroy, Parkland, Irving, Ukida, fimbrectomy. All are permanent, different in technique or reversibility. Primary amenorrhea, not secondary, is Kallmann syndrome, 46XY, uterus and poor breast are Swyer syndrome. GSI surgery not useful. Let's Go repair. Menorrhagia after NSAID fail is hormonal therapy, pelvic organ support, levator ani, scar endometriosis, least hysterectomy. After that, best surgery for vault prolapse in a fit patient is transabdominal sacropexy. Young women with vault prolapse, not hysterectomy, which is not recommended during pessary. 75-year-old woman with procedentia is medically unfit, is we go for Lefort repair. Drug not useful in endometriosis. Estrogen drug of choice for moderate to severe endometriosis is GnRH agonist. They induce hyperestrogenic state, endometrial atrophy. Best time to conceive in a patient with endometriosis immediately after surgery. Disease recurrence is increased with time. Fertility window is best just after surgical clearance. Doses of ulipristal for the emergency contraception, 30 mg single alone. Mechanism of action of ulipristal, it is a progesterone receptor modulator, delay ovulation, suppress endometrium, inhibit implantation. A 18-year-old with amenorrhea, normal breast, female external genital of 5 alpha diagnosis, male pseudo hermaphrodite. Genotype 46XY, testosterone not converted to dihydrotestosterone, female phenotype at birth. So male. Most common cause of uterine rupture, previous cesarean section, scar dehiscence. Scar rupture is the commonest cause, especially during the trial of labor. Classical clinical sign of uterine rupture is fetal part palpable per abdomen due to loss of uterine integrity. Fetus extrude into the uterine cavity. Peritoneal cavity. Management of uterine rupture, immediate laparotomy, life-threatening emergency repair of hysterectomy depend on extent. Nulliparous women with congenital prolapse, surgery of the choice is Shirodkar sling or Khanna sling. Abdominal sling procedure preserve fertility. Less than 40-year-old women with uterine prolapse, family not completed, best surgery is Fothergill, that is Manchester operation, preserve uterus, used in young women with cervical elongation. Greater than 40 with completed family vaginal hysterectomy with pelvic floor repair. Old unfit, Lefort, vault prolapse, sacropolpexy, endometriosis, never estrogen, oliprostol 30 mg for 5 day, uterine rupture, previous cesarean section, then 5 alpha reductase, male pseudo hermaphrodites. After that, investigation for endometriosis is gold standard is laparoscopy. After that, POPQ classification it is for this. And after that, oral contraceptive absolute contraindication are thromboembolism, ischemic heart disease, breast cancer, hepatic tumor, severe liver disease, severe hypertension, pregnancy. Not a contraindication is hypothyroidism. After that, primary amenorrhea, 17-year-old with absent uterus, absent ovaries, bilateral inguinal masses, hypogonadotropic hypogonadism. Then Asherman syndrome, postpartum hemorrhage. Then Asherman syndrome, risk highest in dilation and curettage done for postpartum hemorrhage. Postpartum uterus is large and raw and extensive curettage, endometrial destruction, intrauterine adhesion, treatment hysteroscopic adhesiolysis. Then emergency contraception, ulipristal 30 mg single dose, give within the 5 days. After that, progesterone release, how much progesterone per day? 65 microgram per day. Endometriosis investigation is gold standard is laparoscopy. Endometriosis clinical clue is dysmenorrhea, tenderness, nodule in the posterior fornix with fixed retroverted uterus, indicate endometriosis. It is important, मतलब टेंडर नोड्यूल होना चाहिए posterior fornix में, dysmenorrhea and fixed retroverted uterus. पेल्विक ऑर्गन प्रोलैप्स होता है दो की ए बी ए पी बी पी सी डी, which is not a contraindication. Hypothyroidism, Asherman syndrome, highest after dilation and curettage done for postpartum hemorrhage because large postpartum uterus, extensive endometrial damage. Treatment of Asherman syndrome, hydroscopic adhesiolysis, direct lysis of intrauterine adhesion, uterine prolapse, women with stage 2 uterine prolapse na, so sling operation. Preserve uterus and fertility. Which procedure is best for nulliparous? Is Shirodkar या Khanna? Done is dose of ulipristal 30 mg single dose. After that, precocious menstruation versus precocious puberty. Precocious menstruation, menstruation before 10 year. In McCune or Bright syndrome, precocious puberty, any secondary sexual character before 8 year or menarche before 10 year. After that, वही ब्लड लॉस ग्रेटर देन 80 ml, ब्लीडिंग एट और रेगुलर, तो ट्रीटमेंट क्या होगा? मेडिकल NSAID, ट्रेनेमेक्सिक एसिड, इफ नॉन हार्मोनल फेल होएगा तो OCP देंगे, LNG IUCD देंगे, GnRH अगोनिस्ट देंगे, और मेडिकल फेल होएगा तो एंडोमेट्रियल एब्लेशन करवा देंगे, यूट्राइन आर्टरी एम्बोलाइजेशन, और लास्ट ऑप्शन हिस्टेरेक्टोमी करवा दो. हार्मोनल थेरेपी नेक्स्ट स्टेप है, तो आफ्टर फेलियर ऑफ नॉन हार्मोनल थेरेपी. नॉन कॉन्ट्रासेप्टिव बेनिफिट क्या होता है? डिक्रीज द ओवेरियन कैंसर, है ना, एंडोमेट्रियल कैंसर डिक्रीज करता है, बिनाइन ब्रेस्ट डिजीज डिक्रीज, एक्टोपिक प्रेगनेंसी यूज्ड इन PCOD, एंडोमेट्रियोसिस, डिसमेनोरिया. नोट ए बेनिफिट इज प्रोटेक्शन अगेंस्ट STD, HIV, बैरियर मेथड प्रिवेंट करते हैं. सेकेंडरी एमनोरिया इज सीहान सिंड्रोम, एसरमान सिंड्रोम, टर्नर सिंड्रोम. नॉट ए कॉलमन सिंड्रोम. कॉलमन GnRH डेफिशिएंसी, प्राइमरी एमनोरिया एसोसिएटेड विद अनोजमिया. देन Highest risk of dilation and curettage done for the in Asherman syndrome, done for the postpartum hemorrhage, because postpartum uterus is large and raw, more endometrial destruction, adhesion, definition, intrauterine adhesion, hysteroscopic adhesiolysis. Then general urinary incontinence, stress incontinence is cali repair, pesi repair, peria, TVT, TOT, Bird's Culpo suspension, but not let's go. Let's go is for VVF. देन स्कार एंडोमेट्रोसिस हो गया, सर्जरी में मोनली जो नहीं होती वो हिस्ट्रेक्टोमी होती है. बीलिंग मेथड, सर्वाइकल म्यूकस मेथड, ऑल्सो कॉल्ड एज ओव्यूलेशन मेथड. एस्ट्रोजन फेज क्लियर, स्लीपर, इलास्टिक, वेट डे. प्रोजेस्टेरोन फेज थिक, स्कैंटी, ड्राई डेज. Barrier prevent STD, lactational effective up to 6 months, IUCD, long term coital independent, hormonal, highly effective, non coital, post coital emergency use, surgery permanent, precautious menstruation less than 10 year, menorrhagia after NSAID, field hormonal therapy, OCP, non contraceptive use except STD prevention, secondary amenorrhea not causes, Kallman syndrome, SR1 higher risk, PPS, curettage, GSI surgery not useful, let's go, scar endometriosis, least hysterectomy, billing method, cervical mucus. Next, precocious menstruation is defined as less than 10 year, McCune-Albright syndrome, menstruation before 10 year, and it is the peripheral precocious puberty. ठीक है, प्रिकॉशियस मेंस्ट्रुएशन हो गया. आफ्टर दैट वुमेन रेगुलर साइकिल, मिनोरेजिया 3 मंथ, नो हॉर्मोनल फेल, नेक्स्ट वी गो फॉर द हॉर्मोनल थेरेपी. लास्ट सर्जरी. डेफिनेशन ऑफ मेनोरेजिया इज हैवी बट नॉर्मल रेगुलर मेंस्ट्रुअल साइकिल ग्रेटर देन 80 ml ब्लड लॉस विद 8 days विद रेगुलर साइकिल. नॉन कॉन्ट्रासेप्टिव बेनिफिट ऑफ OCP सारे के सारे जैसे BEO दैट इज ब्रेस्ट कैंसर, एंडोमेट्रियल और ओवेरियन कैंसर डिक्रीज करता है. इसके अलावा शायद ये एक सेकंड में अभी देख के ही बताती हूँ. ये था ना कि ब्रेस्ट है ना, एंडोमेट्रियल और ओवेरियन डिक्रीज करता है, और PCOD, एंडोमेट्रोसिस और डिस्मेनोरिया में भी ये यूज किया जाता है. आफ्टर दैट सेकेंडरी एमनोरिया नॉट ए कॉज विच इज कालमान सिंड्रोम हो गया. एसरमान सिंड्रोम हाईएस्ट. इफ पोस्टपार्टम ट्रीटमेंट क्या हो जाएगा, वो एडिजियोलाइसिस कर दो, सर्जरी नहीं होती, वो अपन को पता ही है ना. बेस्ट क्या होती है, सर्जरी इन विच ऑफ द फॉलोइंग इज यूज्ड इन TVT, TOT, बर्ड्स कल्पोसेंशन है ना. उसके बाद क्या हो जाएगा, बिलिंग मेथड क्या, रिफर टू सर्वाइकल म्यूकस मेथड. सर्वाइकल म्यूकस फर्टाइल फेज में क्या होएगा, कॉपियस, क्लियर, स्लिपरी और इलास्टिक. प्रिकॉशियस मेंस्ट्रुएशन इज लेस देन 10 ईयर. ये याद रखना बस कि प्रिकॉशियस मेंस्ट्रुएशन क्या होता है, जब इट इज़ फॉर द लेस देन 10 ईयर है ना. मेंस्ट्रुएशन बिफोर 10 ईयर प्रिकॉशियस मेंस्ट्रुएशन. और प्रिकॉशियस प्यूबर्टी क्या होती है, लेस देन 8 ईयर. आफ्टर दैट साल्पिंग्स मतलब होता है फेलोपियन ट्यूब. हाइड्रोसाल्पिंग्स होता है फेलोपियन ट्यूब डायलेटेड एंड फिल्ड विद द फ्लूइड है ना. और क्या हो जाएगा, लेप्रोस्कोपिक क्रोमोपर्ट्यूबेशन होता है, इंजेक्शन ऑफ द डाई थ्रू द सर्विक्स, सीन स्पीलेज फ्रॉम द ट्यूब ड्यूरिंग लेप्रोस्कोपी. कन्फर्म द ट्यूबल लेटेंसी, वेलवेट, पेल्विस, एडेजन, एंडोमेट्रोसिस. कॉर्नल वर्सेस डिस्टल ब्लॉक क्या होता है, bilateral corneal block commonly due to tubal spas, mucus plug. Next step, hysteroscopy, laparoscopic chromoprotubation. Why? Because hysteroscopy can open false block, avoid unnecessary surgery. Bilateral distal block, usually true pathology, PID, TB, adhesion. Next step is direct laparoscopic chromoperturbation. Astheno is like decrease the astheno means weak, so weak movement, so decrease the sperm motility. Terato is monster looking, so it is abnormal morphology. Oligo, decrease the sperm count, oligo for the number. Now menorrhagia, meno means मेनोरेज, मेनो मतलब मेंस्ट्रुअल साइकिल, रेजिया मतलब ब्लीडिंग, सो हैवी ब्लीडिंग विद रेगुलर साइकिल. मेट्रोमेनोरेजिया, मेट्रो मीन्स यूट्रस है ना, मेनो मीन्स हैवी, मेट्रो मीन्स इन बिटवीन, सॉरी इन बिटवीन मतलब इरेगुलर, इंटरमेंस्ट्रुअल. मेनो मतलब यूट्रस, menstrual bleeding, and oregia is heavy plus irregular bleeding is metromenorrhagia. Oligo, infrequent cycle length greater than 35. Hypo, scanty bleeding, normal cycle interval. Dysmenorrhea, painful. Meno means amount, metro means timing, oligo frequency, hypo volume, dys pain. Tubal block location matter. Proximal not equal to distal, management differ. Sperm defect, count, movement, shape, menstrual disorder, separate amount, timing. Now endometriosis is again common site are pelvic peritoneum, pouch of the jugular, uterosacral ligament, ovary, chocolate cyst, recto, vaginal septum. Other are appendiceal, pelvic lymph node. Metastatic are lung, umbilicus, surgical scar seen in almost all organ except spleen, Examination finding uterus fixed, tender, retroverted, posterior fornix, bluish, black, puckered spot, pathognomic, posterior fornix, palpation, thickened, knotted, uterosacral ligament, cobblestone fill, functional hemorrhagic ovarian cyst, reticular pattern, blood, hemorrhagic cyst, reproductive age, asymptomatic, conservative management, repeat USG after 6 to 12 weeks, most resolved, CA 125, not specific, surgery not done, MRI is not the first line. Size base less than 5 cm, observe 5 to 7 serial USG, 7 cm MRI or surgical evaluation. Okay, after that reticular pattern is good, that is it is a hemorrhagic system. Yeah, after that vault prolapse, fit for the surgery, transabdominal sacrocolpopexy, not fit, transvaginal sacrospinous fixation, not recommended, ring pessary only for the elderly or unfit, primary amenorrhea, no menses for 13 year with no secondary sexual, no menses for 15 year with secondary sexual character, 14 year with tenor stage 1 is primary amenorrhea. कहा ना, copper IUCD acceptable insertion time is immediately postpartum within 48 hours up to day 5 to 7 of menstrual cycle. This is important. Within the 7 days before next cycle is not true because ovulation may have occurred. So day 5 to 7 of menstrual cycle. Heavy bleeding, smooth globular mass through the cervix, diagnosis myomatous polyp seen in perimenopausal women, origin submucous fibroid protruding through the cervix. Adenomyosis is multiparous woman, chronic pelvic pain, dysmenorrhea, MRI, thickened junctional zone, uterus symmetrical, enlarged and tender. Pelvic organ prolapse complication are hydronephrosis, hydroureter, incarcination, decubitus ulcer, stress incontinence, rarely squamous cell carcinoma, but not a complication is urge incontinence. Hormones secreted by granulosa cell are estrogen, not LH or FSH or progesterone. Follicular phase, follicle graphion, follicle estradiol, increase endometrial proliferation. After that, bluish black puckered spot seen on posterior fornix on specular examination is diagnosis of endometriosis. On vaginal examination, thickened nodular uterosacral ligament give a cobblestone feel. Cobblestone feel, again I think it is the endometriosis. After that, third, USG show a ovarian cyst with reticular pattern. It is a वो है hemorrhagic cyst. Hemorrhagic cyst next step is CA 125 नहीं, immediate surgery no, MRI pelvis will give for the metastasis. So node का metastasis there is no. So repeat USG after 6 to 12 week is true. Which ovarian cyst USG pattern suggest hemorrhagic? It is a reticular या lace pattern. Best management for vault prolapse in a young woman fit for the surgery is the transabdominal sacrocolpopexy. Not recommended in vault prolapse is ring pessary. Primary amenorrhea is defined as the प्राइमरी एमनोरिया तो वही होएगा नो 13 नो मेंस्ट्रुएशन विदाउट ब्रेस्ट 15 विद ब्रेस्ट विच पेशेंट ऑफ प्राइमरी एमनोरिया 11 ईयर टेनर स्टेज 1 13 विद और 15 विदाउट नहीं 13 विदाउट so 13 without 13 tenor 5 no 14 tenor 1 is true. Copper IUCD can be inserted in all except immediately या within the 7 days before next cycle no, it is day 5 to 7 of menstrual cycle. 42-year-old woman with heavy bleeding with a smooth globular mass protruding through the cervix. This diagnosis is myomatous polyps. MRI show thickened junctional zone, suggest thickened junctional zone. I think it is thickened junctional zone is adenomyosis. Okay, note a complication is urge incontinence. Hormone from granulosa cell secrete the estrogen, FSH and LH from the pituitary and progesterone from the luteal phase. Hormone causing endometrial proliferation is the estrogen. Next, vesicovaginal fistula most useful test is cystoscopy. Direct visualize site size, number of fistula, show relation to ureteric orifice, assess bladder mucosa injury. 3 swab test only to differentiate type of GI fistula. MRI rarely needed. Cystometry for the incontinence, not for the fistula. Abdominal sling surgery, fertility preserving. POP surgery, correct site of the mesh attachment is sacral promontory wise, strong durable support, preserve fertility used in sacrocolpoxy. Symphysis Strong, durable support, preserve fertility used in sacrocolpopsis, symphysis, pubis, ischial tuberosity, ischial spine, incorrect fixation points. ठीक है. Scar endometriosis least likely surgery to cause is hysterectomy because no active endometrium left to implant. Surgery commonly used scar are breast hysterectomy, cesarean section, myomectomy, ventrofixation, episiotomy. Most effective reversible contraception is no plant. Um, and most effective oral is sterilization. Image based is AUB, intramural fibroid, because well circumcised film walled cut surface and enlarged uterine cavity. It is not myomatous pelvic because it protrude into the cavity. Ideal time for the postpartum IUCD within 24 hours to 48 hours of delivery. Primary dysmenorrhea, it is dependent on psychological factors. Start just before or at onset of menstruation. No pelvic pathology common in adolescent. No pain after hearts. Now tubal ligation, most common site isthmus due to uniform muscle thickness. Why? Reliable occlusion, less failure, easily reversible. Suspect endometriosis, infertility, dyspareunia, pouch of Douglas. Next step is TVS. First line investigation can detect chocolate cyst. Fibroid या secondary changes या complication. Secondary changes hyaline cystic degeneration, calcification, red degeneration, sarcomatous change. Complication torsion, hemorrhage, ulceration, infection, inversion of uterus, endometrial hyperplasia, associated adenomyosis, parasitic fibroid. Then myomectomy, advantage preserve uterus and fertility, effective for HMB and pressure symptom. Disadvantage, new fibroid clone can form. Procedure of choice, hysteroscopic myomectomy, intracavitary fibroid, vaginal myomectomy, prolapse fibroid. Instrument is bone, neck, clamp or myoma screw. VVF, cystoscopy, fertility preserve, POP surgery, sacral promontory, scar endometriosis least after hysterectomy. Best reversible contraception implant, PP, IUCD 24 to 48 hour. Primary dysmenorrhea, psychological, tubal ligation site is isthmus, endometrial workup, TVS first. Most useful investigation to locate and assess the vesicovaginal fistula. Most useful investigation to locate and assess the vesicovaginal fistula. If it is about, we will diagnose by 3 swab tests, but if it already is vesicovaginal, then most useful investigation is cystoscopy. In abdominal sling surgery done for uterovaginal prolapse with fertility preservation, mass is fixed too. It is sacral promontory. Which surgery is least likely to followed by scar endometriosis? It is a hysterectomy because there is no functional endometrium left. Na? Most effective reversible method is node plant. A hysterectomy specimen show a well circumcised field walled mass in the uterine wall. Diagnosis is the it is the myomatous polyp or intramural fibroid. It may be intramural fibroid because it is the ideal time for the insertion of postpartum is 24 to 48 hour. Post placental is 10 minutes. Then primary dysmenorrhea is true that it is a psychological factor and it occur during or during या थोड़ा सा पहले होता है. After that, most common site for tubal ligation and region, ampulla. Most common site of tubal ligation is isthmus because it is a uniform muscle thickness. Ampulla is not, है ना. A woman with infertility, dyspareunia, retroverted uterus and pouch of Douglas tenderness. ये तो लेप्रोस्कोपी हो गया. तो नेक्स्ट स्टेप क्या होता है? नेक्स्ट स्टेप ये तो वो है एंडोमेट्रियोसिस. नेक्स्ट स्टेप इज TVS. विच ऑफ द फॉलोइंग इज नॉट ए कॉम्प्लिकेशन ऑफ पेल्विक ऑर्गन प्रोलैप्स? इट इज़ द हाइड्रोनेफ्रोसिस होती है, इनकार्सिनेशन होती है, स्ट्रेस इनकॉन्टिनेंस भी होती है, अर्ज इनकॉन्टिनेंस नहीं होती. सो या आफ्टर दैट मेरे को एक चीज़ देखनी थी, इसका ट्रीटमेंट क्या होता है प्राइमरी डिस्मेनोरिया का? प्राइमरी डिस्मेनोरिया का ट्रीटमेंट GnRH एनालॉग नहीं होते. हाँ, NSAID और OCP होता है. NSAID एंड OCP. ठीक है. नेक्स्ट, एंडोमेट्रियोसिस सिम्टम्स आर इनफर्टिलिटी, डिसमेनोरिया एंड इरेगुलर वेजाइनल ब्लीडिंग. एंड है ना. आफ्टर दैट, एनेंसेफेली इज नॉट सीन इन एक्सीडेंटल कंसेप्शन, रिदम मेथड फेलियर, नो इंक्रीज कंजेनाइटल एनोमली. एनेंसेफेली, फॉलिक एसिड डेफिशिएंसी, नो कॉन्ट्रासेप्शन फेलियर. है ना. आफ्टर दैट, प्राइमरी अमनोरिया विद इंग्वाइनल मासेज आर हाइपरगोनेडोट्रोफिक हाइपोगोनेडिज्म. Clues are no breast, no pubic hair, absent uterus and tubes, inguinal mass, undescent testes, XY disorder. Now endometriosis investigation, diagnostic laparoscopy with biopsy. First investigation TVS, management asymptomatic, observed symptomatic, medical management, then laparoscopic surgery. Then fibroid indication for the treatment is treat if infertility या corneal या submucous fibroid size greater than 12 week, pedunculated fibroid, pressure symptom, rapid growth in menopause and diagnosis uncertain, laparotomy. Hormone secreted by granulosa cell, that is the follicular phase, estrogen या PCOD treatment are all except clomiphene, letrozole, laparoscopic ovarian drill. It is all except उलीप्रिस्टल. उलीप्रिस्टल इज SPRM ना, ये क्या है इसका, तो प्रोजेस्टेरोन का वो होता है. लिगामेंट इंजर्ड इन यूट्राइन प्रोलैप्स, इट इज़ द मैकनरॉन्ट या कार्डिनल लिगामेंट दैट प्रिवेंट यूट्राइन डिसेंट, इंजरी यूट्राइन प्रोलैप्स. मिस्ड कंबाइंड ओरल पिल मैनेजमेंट, मिस्ड greater than 2 pill greater than 48 hour, discard pack and start new pack immediately, use barrier contraception. इसको मैं आगे समझाऊंगी अच्छे से. नेक्स्ट, एंडोमेट्रियोसिस सिम्टम, पेन, इनफर्टिलिटी, रिदम, नो कंजेनिटल एनोमली, इंग्वाइनल मास, नो यूट्रस, XY डिसऑर्डर, फिब्रॉइड, ट्रीट इफ ग्रेटर देन 12 वीक, इनफर्टिलिटी, प्रेशर, ग्रैनुलोसा हार्मोन, एस्ट्रोजन, PCOD, ड्रग नॉट इंक्लूड ओलीप्रिस्टल, है ना, सर्वाइकल प्रोलैप्स, यूट्राइन प्रोलैप्स, कार्डिनल लिगामेंट, मिक्स्ड OCP, डिस्कार्ड कर दो. अगेन सेम चीज़ है इसमें. एंडोमेट्रियोसिस का वो पूछा है तो इनफर्टिलिटी होता है, डिस्मेनोरिया होता है, वजाइनल ब्लीडिंग होता है, एनेंसिफेली नहीं होता, प्राइमरी डिस्मेनोरिया का ये हो जाएगा, हाइपरगोनेड्रोट्रोफिक होता है. गोल्ड स्टैंडर्ड इन्वेस्टिगेशन क्या होती है एंडोमेट्रियोसिस की है तो वो जाएगी लैप्रोस्कोपी हो जाएगी. देन एसिम्टोमेटिक फाइब्रॉइड का ट्रीटमेंट कब करेंगे, जब फाइब्रॉइड ग्रेटर देन 12 वीक साइज होएगा. ओवेरियन, which hormone is secreted in high amount by ovarian granulosa cell, estrogen, all the following, PCOD, उलीप्रिस्टल नहीं होता. which ligament is prevent uterine descent, most important कौन सा होता है to prevent, it is the cardinal और मैकनरॉड ligament. देन वुमेन 3, ये अभी रुक जाओ. एंडोमेट्रियोसिस की मोस्ट कॉमन साइट क्या होती है, मोस्ट कॉमन साइट होती है ओवेरी, ग्रेटर देन पाउच ऑफ डगलर, और स्प्लीन इसमें नहीं होते हैं. ठीक है. नेक्स्ट क्या हो गया ये कंप्लीट. आफ्टर दैट इसके बाद हो जाता है एसिम्टोमेटिक फाइब्रॉइड की ट्रीटमेंट तो आएगी. रैपिड कब कब करनी होती है, जब इनफर्टिलिटी हो, कॉर्नियल फाइब्रॉइड, ट्यूबल ब्लॉक हो, सबम्यूकस फाइब्रॉइड, हैबिचुअल अबॉर्शन, साइज ग्रेटर देन 12 वीक, पेडिंकुलेटेड फाइब्रॉइड जिसमें टॉर्जन होए, है ना, कॉर्नियल फाइब्रॉइड ब्लॉकिंग द ट्यूब, और सब म्यूकस फाइब्रॉइड जिससे हैबिचुअल अबॉर्शन हो जाए. प्रेशर सिम्टम, यूरेटर, ब्लैडर, रेजिडुअल यूरिन, UTI, रैपिड ग्रोथ इन पोस्ट मेनोपोजल वुमेन, डायग्नोसिस अनसर्टेन, लैप्रोटोमी नीडेड. एग्जाम क्लू, स्मॉल कैल्सिफाइड एसिम्टोमेटिक फाइब्रॉइड, ऑब्जर्व, बिग प्रेशर, इनफर्टिलिटी, ट्रीट. आफ्टर दैट thick and junctional zone greater than 12 mm seen in adenomyosis. Yeah. After that dysmenorrhea, menorrhagia, 35-year multiparous uniformly enlarged tender uterus, 10 to 14 week, it is the adenomyosis. Again important. After that myomectomy, infertility ड्यू टू फाइब्रॉइड इज ट्रीटमेंट, है ना. आफ्टर दैट यूट्राइन आर्टरी एम्बोलाइजेशन से तो फर्टिलिटी डिक्रीज होएगी. GnRH अलोन टेम्परेरी होता है. एक्सपेक्टेंट मैनेजमेंट, इनफर्टिलिटी परसिस्ट. हार्मोन सिक्रेटेड बाय ग्रेनुलोसा सेल इज एस्ट्रोजन फॉलिकुलर फेजेस के अंदर. आफ्टर दैट pelvic, a postmenopausal woman present with a mass protruding from that is increase on cuff, विच इज़ नॉट ए कॉम्प्लिकेशन. ये कौन सी नहीं होती, अर्ज इनकॉन्टिनेंस नहीं होती, इनकार्सिनेशन ये सब तो होती है. इंडिकेशन टू ट्रीट एसिम्टोमेटिक फाइब्रॉइड, है ना, एंड ट्रीटमेंट फाइब्रॉइड ग्रेटर देन 12 वीक, है ना. और अगर सब म्यूकोजल होता हो तो वो भी हो जाता. बाकी तो इंट्राम्यूरल, सबसिरोसल है और कैल्सिफाइड है, ये तो नहीं होते. MRI शो थिक जंक्शन जोन, ये तो हो जाएगा अपना एडिनोमायोसिस. विच इज़ ए बेस्ट इंडिकेशन फॉर मायोमेक्टोमी, मायोमेक्टोमी अपन देते हैं जब इनफर्टिलिटी ड्यू टू फाइब्रॉइड होए, है ना. आफ्टर दैट हाईएस्ट अमाउंट ऑफ है ना, हाईएस्ट. इसके अलावा फोर्थ कहाँ है, इट इज़ द बेस्ट इंडिकेशन फॉर मायोमेक्टोमी हो गया. पोस्ट मेनोपोजल ब्लीडिंग, सस्पेक्ट मैलिग्नेंसी, हिस्टेक्टोमी करवाते हैं, है ना. एसिम्टोमेटिक में कुछ करवाते ही नहीं है. देन ग्रेनुलोसा सेल हो गया. मोस्ट कॉमन साइट ऑफ एंडोमेट्रियोसिस ओवेरी, है ना, चॉकलेट सिस्ट होता है. एंड यूट्रोस ऑर्डर इज ओवेरी, पाउच ऑफ डगलर, देन यूट्रोसेकुलर. PCOD नॉट यूजफुल treatment ulipristal because it is used in emergency contraception. Ligament preventing uterine descent, cardinal ligament. After that, round ligament maintain anteversion uterosacral secondary support, broad ligament peritoneal fold, prolapse is cardinal ligament. Gold standard is diagnostic laparoscopy, TVS is first investigation. Most common degeneration is hyaline degeneration, occur in 60% of fibroid cystic, less common rare degeneration, pregnancy related sarcomatous change is rare, है ना. पीओपी स्ट्रेस नोट अर्ज फाइब्रोइड 12 वीक थर्ड हाइलिन डिजनरेशन हो गया. आफ्टर दैट फर्स्ट टायर लेस देन 2 डिग्री IUCD implant sterilization, secondary tire hormonal, oral injected transdermal patches, transvaginal ring, third tire barrier fertility awareness method, fourth is spermicidal preparation. Next, oral pill combined OCP Bala D levonorgestrel 0.5 ethylene estrol 0.03 milligram ferrous fumarate, Mala and levonorgestrel 0.15 mg ethylene estrol 0.03 mg ferrous fumarate, and it is free. Progesterone only pill suitable for lactating women, norethistone 350 microgram, then norgestrel 75 microgram, levonorgestrel 30 microgram. Once a month or long acting pill, highly disappointing result, quinastrol and gossypal male pill, cottonseed derivative and cause azoospermia and severe oligospermia. Postcoital pill या interceptive levonorgestrel 0.75 mg, 2 doses 12 hours apart. Mifepristone 10 to 600 mg, ulipristal 30 mg within 5 days of intercourse. Centpromen 60 mg 2 tablet within 24 hours of intercourse. GnRH agonist CUT IUCD inserted within the 5 day. Injectable contraceptive progesterone only injectable, DMP 150 mg IM every 3 months, NAT-EN 200 mg IM every 2 months. Combined injectable cyclophem, DMP 25 mg ethylene cypionate 5 mg, Mesigna NAT-EN 50 mg estradiol valproate 5 mg. Subdermal implant estradiol Mesigna. Subdermal implant are Norplant 1 levonorgestrel 35 mg, Norplant 2 or Jedel 2 rod with levonorgestrel 70 mg in each and release at a rate of 50 microgram per day. Others are hormonal IUCD, that is Mirena, which contain levonorgestrel 52 mg with release rate of 20 microgram per day. Ortho Evra patch norgelistomin ethylene estradiol weekly for 3 weeks, then patch free for 1 week. Vaginal ring or NuvaRing ethonogestrel ethylene estradiol daily release, use for 3 weeks with withdrawal for 1 week. After that, these are complete. Myomectomy is retain uterus and hence preserve childbearing function, effective for heavy menstrual bleeding and pelvic pressure. Disadvantage, formation of new clone of abnormal myocyte. Hysteroscopic myomectomy is the procedure of choice for removing intracavitary myoma. Vaginal myomectomy is preferred in cases of fibroid prolapse through the cervix. Indications for treatment in asymptomatic fibroid, that I will already tell. Finally complete.